We're going to be saying, may the 4th be with you. And of course, this is not the pain you're looking for, everybody, okay? So in today's session, we're going to be talking about chronic pain. So I'd like to welcome everybody. I'm George De Silva. I'm the engagement coordinator for today's session. And if you have any comments, you'll see later on in the slide deck. And when we post it on our website also, you can reach out and contact me. I'm the one that sent you all the links, sent you all the emails. So if I've overdone it a little bit, I do apologize. But if you need anything, please feel free to send us a message in the chat room or send me a private email after today's session. And just to remind everybody, we're going to have a live yoga demo. So please, if you're ready to and you're comfortable with, get your yoga mat ready. Ron's going to go and walk us through he's going to be our Yoda of yoga today. So I am going to pass it over to Francisco to help us do an acknowledgement and give us a little prep before we start.
Thank you, everybody, for being here. My name is Francisco Ibanez Carrasco, and I'm from the Dalai Lama School of Public Health at the University of Toronto. And I acknowledge that we are in Toronto, in the land of many First Nations, Métis, and Inuit folks. And I'm sure you across the world also join us in the cause of repairing the colonization effects amongst Indigenous peoples across the world. So thank you for that. Thanks, George.
So Francisco, can you walk us through a little bit of tech check and our site and everything that's going on? Okay,
so the session is being recorded and only the speakers' parts of the session will be edited, and we will send those to everybody who's participating for their approval. We ask you, as always, as in any other meetings, to keep your microphones muted, but we encourage all your questions, both in writing and at times verbal. We'll let you know when. Please direct all your questions to the chat room. And we remind you that the private chat function is enabled, and that is kind of semi-private because the reality is Zoom, when it records, it actually produces a text transcript of all that you've written. So, and we ask you to not grab any screens, please. So that's that. Thank you, George.
We have a great panel here for you. So even going with our theme of today's May the 4th be with you, we even have himself, the Vader, there too. So I'm going to ask each of our panelists to give us a brief description of themselves, starting with Mr. Vader. So Kyle, please.
Hi, everyone. Really happy to be here and glad this aligned with my last name today. So that's good. So my name is Kyle Vader. I'm a physiotherapist by clinical background. I work within an interprofessional chronic pain program at Kingston Health Sciences Centre in Kingston, Ontario. And I'm also a PhD candidate in rehabilitation science at Queen's University. Much of my research focuses on rehabilitation approaches for the management of chronic pain, of which physical activity and exercise plays a really pivotal role. I've also done some research with Kelly O'Brien in the context of rehabilitation for people living with HIV. So I look forward to the conversation today.
Thanks, Kyle. And all the way from wonderful UK, we have Joe. Joe, please introduce yourself for us.
I'm the light side, obviously, as Kyle is the dark. Apart from the wonderful UK, I know Kelly O'Brien. and other people like Francisco involved in this, because I met them in 2009 when the then Canada UK, now Canada International HIV Rehabilitation Research Collaborative was first established. I live with HIV, so I was one of the first community members to join that group. I now do communications in the sense that I handle media and communications with other stakeholders like the government, with and for the British HIV Association. I also am on the steering group of the UK Community Advisory Board, which is 800 treatment activists across the whole of the UK. And I'm co-chair of a women's HIV charity, the Sophia Forum. Sophia means knowledge. Forum is like talking about it. And I've become increasingly involved with pain in the sense of pain research, because I myself live with chronic pain. So that's not actually anything except completely selfish. I want to find out more and change things for the better, because it'll make it good for me as well as for many other people.
Thanks, Joe. Fantastic. And we have Colleen Price. So Colleen, please give us a little bit about yourself and what you're all about.
Hi, everyone. Good day. I couldn't be more pleased that we're having this session. I'm a survivor of trauma, hepatitis C, HIV, substance use, mental health. I underwent hepatitis C treatment in 2004 to 2005, and I was very fortunate that I cured my hepatitis C. The engagement in clinical care transformed my health and my life. I am HIV positive 20 years, and I've lived with chronic pain for 30 years. Engaging in care, I mean, prior I had serious substance use issues, and engaging in my health, like I said, transformed my life. My clinician involved me in research, and post-hepatitis C treatment, I became an advocate. I joined the Canadian Treatment Action Council, and I worked very closely with Ron, and I started a co-infection portfolio. And I am now very focused on chronic pain and HIV. I'm trained in psychology, sociology, and as a social service worker. It was the barriers in the hepatitis C treatment that caused me to become an advocate. I have served OACHA for 10 years, no longer, but remarkable work. I also served the OHGN Ontario Cohort Governance Committee for 8 years. And I've been an advocate, a community-based researcher for the last 15 years. Right now, I've been, co-infection was a handful. There was no funding. There were no experts. It took 7 years really to get things up and going. And now I'm very focused on doing the same with chronic pain. We don't know the numbers in Canada. There's so much work that needs to be done in research. As engagement in clinical care transformed my life, I also believe that engagement in exercise programs like the ones I'm working with Kelly and Francisco and team, I think that they can also really have huge potentials for engagement in clinical care via the program or, information and community. So, I'm excited to be here. And I'm co-chair of the Clinical Trials Network Chronic Pain and HIV Working Group. We've got tremendous things going on, and I'll discuss a little bit later in initiatives and that type of thing. Anyways, thank you and welcome everyone. This is so important. There's so many of us impacted, and it takes everyone to help.
Thank you, Colleen. Perfect. Thank you. And finally, we have Ron Rosenes. Ron, now that you're seated somewhere else instead of your yoga mat, please tell us a little bit about yourself and what you've been able to accomplish. You're muted, Ron. There you go.
Hi, everyone. I'm in my office now. You can see my little treadmill in the background. I am a community health advocate. I think it's the best way to describe what I do as someone who has been living with HIV since before the virus had a name, and probably more than 40 years now. I think of myself, therefore, as a long-term survivor. I think of myself as a witness, and really not just a witness to the tremendous loss of friends and colleagues working in this field over the years, but also a witness to the tremendous scientific progress that we've managed to make in the field of HIV. I also think of myself as a pioneer because I'm really a member of the first cohort of people aging with HIV. And I've worked closely with Colleen, as she mentioned, on access to health, to medications. I am currently the chair of the HIV Legal Network, and I think that really speaks to my interest, not just in the biomedical aspects of HIV, but also in the degree to which certain groups of people are made more vulnerable to HIV by their lower socioeconomic status, by issues related to health equity and social justice, all areas that are of great interest to me, and that are really special about HIV and its ability to seek out certain groups of people made more vulnerable, as I say, by the intersection of substance use and poverty and particularly race and the stigma that comes with HIV. All of those things have been of great interest to me in my work and in my research. So I'm also a community-based researcher, but I've worked on research studies that are clinical, epidemiological, and even in basic science, where I chair the community advisory board on the Can Cure grant, which is looking at a search for a cure for HIV. Thrilled to be here. I was a member of Kelly O'Brien's exercise and HIV study, and I enjoy my association with Francisco and everyone there, and Rachel, and all the work that this group is doing, not just here in Canada, but internationally. And you are all testimony to the degree to which this work is taking place on a global level, which I think is really exciting. Thanks.
Thanks, Ron. And as somebody also living with HIV for over 20 years, I commend each and every one of the panelists that are here today to help us learn more about HIV and physical fitness and how we can better ourselves. So we're going to move into our first question, which I'm going to ask is, what is the experience with HIV, physical exercise, and chronic pain? And I'm going to start off with Kyle. So Kyle, can you give us a little bit of an understanding about what pain's all about?
Yeah, thanks, George. So I'm just going to start off here grounding us in a bit of what the literature has to say about pain, understanding that many of you likely come to this call today with your own lived experience of pain. It's actually quite an exciting time in pain research. In 2020, for the first time in over 40 years, the International Association for the Study of Pain updated their definition of pain, which was quite a significant occasion in pain research. So if you look at the infographic here, pain is really an unpleasant sensory, but also an emotional experience. So I always like to highlight that it's not only a sensation that we feel within our body, whether it's a sore back, arm, shoulder, but it also has an emotional component associated with it, which can lead to quite significant amount of suffering and associated challenges with day-to-day activities. Go to the next slide. Now that we've kind of set the stage on what pain is, chronic pain by definition is broadly categorized as pain that has persisted or recurred for greater than 3 months in duration. The reason that we have chosen 3 months as that time frame is really because at this point, this is when, based on tissue healing, we have a good sense that tissues will be healed. So when we're thinking of chronic pain, we're now thinking of more changes that can happen within the nervous system versus changes that are necessarily happening at the structural and tissue level. Again, lots of recent work has come out on this. So again, the International Association for the Study of Pain came out with recent categorizations of chronic pain. As Colleen mentioned, we need more research into understanding the prevalence of chronic pain broadly, but also in specific communities. And the goal of doing this categorization system was to help so that we can better understand what are different types of chronic pain that exist and how common they are. I won't go into the details of this picture, but I will say that chronic pain is multifaceted and can involve varying reasons why pain may occur. It can be a health condition in its own right, but it can also be a symptom of another health condition such as arthritis.
And Kyle, in that 3 months, do you have to be in pain each and every day to be defined as chronic, or is it just pain within the 3 months? Sorry, if you don't mind me asking.
Yeah, really good question. How we typically categorize it is as long as you've had pain that's been recurring for 3 months, that's typically how we categorize it. So it doesn't mean that you've had pain every day for 3 months. However, I will say that from a clinical perspective, 3 months is at the short end of things. Many people that I work with, and I'm sure people on the call here, have spoken about their experience of living with pain for years, not just months. Now grounding us a bit in the topic today of physical activity and exercise. So high quality evidence has shown that physical activity and exercise can help to reduce pain severity, improve physical function, and also likely have positive impacts on psychological function as well as quality of life. Despite this, we know that there are challenges, which I think people on the call can likely relate to, as well as society broadly. Lots of factors can influence participation in physical activity and exercise, and we know that pain is one that can act as a significant barrier. If we focus in on HIV and chronic pain, studies are quite variable. However, current evidence suggests that 25 to 90% of people living with HIV experience chronic pain, which is higher than the general population, where we typically think of 1 in 5 individuals, which would be approximately 20% of the population, which I think is important to note. Again, more research is happening in this area, such as a recent qualitative study that looked at the experience of living with chronic neuropathic pain. And again, I think it speaks to the complexity of pain, the challenges of living with pain, and the challenges of receiving healthcare for pain. And I will leave it at that for now.
Thanks, Kyle. And I'm going to ask the same question for Joe. So Joe, can you talk to us a little bit about your experiences with AIDS?
Most certainly. Could I just say that the last paper that Kyle was citing, explains in a way how I became involved in pain research. The lead author, Whitney Scott, she asked me to become involved. So I went from patient to researcher. And Andrew Rice, Professor Andrew Rice, who is also one of the authors, was the pain specialist, the pain consultant at the Chelsea and Westminster Hospital in West London, which is has an HIV specialist ward, who explained to me why I had the pain, what was causing it, and what I might be able to do in order to improve my life. I don't know about anybody else who's actually here and listening to this, but for me, information really is important. Knowledge really is power. If I understand, I can work with it. That's basically how it goes. I already mentioned that I know Kelly and Francisco because of becoming a member of Kirk. The reason that I became a member goes back to the Chelsea and Westminster Hospital, in as much as I was referred to a specialist exercise clinic there, and indeed to Professor Andrew Rice, by another member of the Canada International HIV and Rehabilitation Research Collaborative. Forgive me if I do keep calling it Kirk from now on, because it is a bit of a mouthful to try and get out. You know, it's not that catchy. Anyway, this was a specialist physiotherapist, and he very kindly referred me into the Chelsea and Westminster. Otherwise, I would never have got there, because unfortunately, there is not a specialism everywhere, in the UK health system at least. My pain is because of neuropathy. That pain, the neuropathy caused pain, started literally at seroconversion stage of HIV. I say that because there is a presupposition that HIV medication may be causal of neuropathic pain. That may be the case with some of the older HIV antiretrovirals, but it certainly is not, as far as I'm concerned. I didn't actually start HIV medication until just 3 years ago. The reason being that I'm one of those oddities. I'm an elite controller. In other words, my body had removed the virus down to an undetectable level, and it stayed like that for 8 or 9 years after the first year of being diagnosed. But it was really chronic. The pain led to me, right from the very beginning, having difficulties walking. I lived in a house with stairs, which was unfortunate. I had to go up and down them on my bottom, but, okay, I did it. The first HIV peer support group I went to had 53 chairs to the entrance, and I got up and down those as well. As you've gathered, I can be determined. But I didn't actually go into a wheelchair until many years later, and I didn't understand why. Again, it was a specialist at the Chelsea and Westminster who explained to me what had happened. It's because the neuropathic pain, to be more exact, the neuropathic sort of paralysis, because neuropathy is so odd. On the one hand, you don't feel things, like I don't feel things with my feet properly, which is called drop foot, which I always think sounds like a sheep that should be put down very quickly. But on the other hand, you feel like you're walking on knives, like the Little Mermaid felt when she got legs so she could meet her prince. You have sharp pain when you're lying down. You have sharp pain when you're standing up and walking. There is no explanation that you can find to it if you are suffering from it. It can be a dull ache. It can be tingling. It can be electric shocks. And in a scale of 1 to 10, you can go from 3 to about 11 on a bad day. I know, I've been there, and I don't know what makes that happen. If I did, I would avoid 11 at all costs. Pain medication, I went through virtually every pain medication available. In fact, I did go through everything that was available at the time, and none of it got rid of the pain. Some of it left me nearly comatose. I watched the most rubbish of soap operas on television, which I had never watched before. I won't say I watched them with interest, but I watched them because I just didn't know what was happening to me. So I thought, it's time to look for other things. I have to get past this pain in other ways, which really is what gets me involved in research and also what got me here today. Now, some of those other things include exercise. However, if you have HIV and you need to explain why you have problems, it can make it difficult to exercise in a mainstream exercise space or environment. People would say to me, depending on how particularly aged or worn I looked on any given day, have you broken your hip? I hated them, absolutely hated them. Did you have an accident while skiing? I liked them. They were absolutely okay. Some informed people, when I said, actually, it's neuropathic pain, you know, the nerves, would go, oh, you're diabetic. No. I would sometimes say it's due to a virus, with a very firm but slightly mysterious look. If you tell people that you have HIV, you have to be prepared for half an hour of conversation and a death face. The death face goes, oh, I'm so sorry. And then you have to get them back up from the death face to, actually, it's fine. And I do talk about living with HIV in the media. It's not like I'm scared to talk about it. It's just, you know, it takes up time. And doing it again and again can really get you. Outside of central London, or other urban centres in the UK, mainly London, there is very, very, very little specialist support for HIV-related pain. Inside central London, there is an excellent clinic called the Cobler Clinic in the Chelsea and Westminster Hospital, where they take people through 10 sessions doing different forms of exercise, also looking at mental health, which is important. I mean, if you don't sleep, you lose it. Let's face it. Every single one of us knows that, let alone feeling just a tiny bit sorry for yourself because you're hurting and you can't exactly share it. You can't say, you know, I feel real like, put your own word in there, because I am suffering really badly from pain today. It's why I'm walking strangely. I use a crutch to walk, which is probably why I get the did you break your hip thing, because I can catch myself with a crutch. If I trip because of my drop foot, I trip because I don't feel the ground. A walking stick doesn't quite hack it in that way. I do my best to keep moving, and I do keep moving because I'm a very stubborn, obstinate, determined person, and I like listening to birds singing, and I like looking at the spring coming, so I go for walks. I may not walk that fast, but I walk for an hour. For me, that is a big achievement. When I was in my wheelchair phase, the wonderful specialist who told me why I was in my wheelchair phase, and also told me that if I didn't start using my wheelchair as a walker, in other words, get out of it, hold it, walk along, get back in it when I couldn't do that anymore, then I would be in a wheelchair. I would be in a wheelchair for the rest of my life. And I had just expected that, because the people I knew from peer support groups that I went to give talks to and stuff, they were, when they went into a wheelchair, that was it. They stayed right there, and I was not going to be that person. So I started using it as a walker. There is a lake with a cafe at one end near where I live. So I would go a bit of a distance, sit down, wheel myself along, get up, walk along using it as a walker, sit down. And I kept doing that. But it took me months before I could get round that lake. When I finally got round the lake, walking the whole way, there's me walking along, grin on face, holding on to chair. And the man in the cafe at the other end said, "You lost someone, love," looking at the empty chair. And I said, "Come on, you've seen me. I've been trying to do this. I've done it." He said, "I'll have a cup of tea on the house then to celebrate." So I did. I did have a cup of tea to celebrate. I may have had something stronger later, but we won't go there. In trying to find ways past the either opioids or cocodamol or amitriptyline or gabaline or whatever, all of the things that I had tried, I got into doing what you will get from Ron's yoga, a sort of mindfulness and meditation by trying the mindfulness theory. It may not be something that works for everyone, but it didn't do too badly for me. But you have to try, you have to keep doing it. It's not like, it's not magic, you know. 2 cocodamol will stop that pain for a very little while. but they're not going to do anything longer term. Breathing deeply, mindfulness, meditation, those things can help. Acceptance and commitment therapy, which is a form of cognitive behavioral therapy, CBT, is a piece of research that I became involved in. But I will talk more about that later when we look at how research is developing in the community now. Thanks for listening.
Thanks, Joe. I got one question for you, because it's sort of that typical question. When it deals with the nerve endings and everything else, how many people or how many doctors came to you and said, well, maybe it's all in your mind? And how did you deal with that?
Well, early on, they not only said it's all in your mind, they did their level best to get me on antidepressants. You know, I had people saying, but you're always wearing black. I'm wearing black now, incidentally. I like black. But, and of course I felt sorry for myself. Why shouldn't I feel sorry for myself? I've just been diagnosed with HIV. It has stopped me working because I can barely walk, you know. For the first time in my life, I'm having to get benefits from the system, which I'm not doing now, incidentally. But I had every reason to feel pathetic. There was no reason, therefore, to go on to antidepressants. And so the pain was perceived to be something I had self-inflicted to justify why I was feeling so low.
Thank you. Thank you, Joe. So we're going to move on to Colleen. So Colleen, same question. What's been your experiences with HIV and physical exercises?
Well, I just going to cover a couple things, but I've experienced every barrier and stigma in my chronic pain management and barriers to therapies. I've never really had help, and I can't afford what I know works. When I go down south, I can get good massages for $20 US, and something as simple as that is really, really helpful. But here it's about $100 an hour, and I've been living with HIV for a really long time, and I am in poverty. I think if you live with HIV long enough, most of us live in poverty, and that's just the single biggest access issues, eh? With regards to barriers, I've also, you know, even a gym, fitting in and stuff like that. I have a substance use background, you know, a little bit different of a background. I had never really paid attention to my health, really, until I went for hepatitis C treatment when I was 40. You know, paying attention to your health is transformative. And, you know, the first steps of even just trying exercise is monumental if you've never, you know, really prioritized your health. Challenges, well, the benefits of exercise. I mean, I've been after Kelly for 2 years at least, and exercise helps my pain greatly. Right now, I take low dose morphine and I use cannabis. And exercise really helps. It also helps me to spare my opiates, meaning, you know, between the exercise and the cannabis, I can cut down on my opiates, which I really tried to do. The opiates, you know, my pain management is self-managed, and it's so-so. Do I think it could be better? Yes, for sure. I think it could be better. But, you know, it's been elusive for 30 years. And, you know, now I'm working very hard with the Canadian Trials Network and wherever I can to try and further wellness for people living with chronic pain and HIV. For me, there's no wellness until I can get a grip on my pain. It impacts sleep, it impacts mood, it impacts relationships, it impacts everything. And, there's been times where I'm really grateful that I'm very resilient, but there's also times where I said, bleep resiliency when I was in so much pain. So, self-management is a very tricky business, but it's also empowering if you can. And, the first step into exercise, if you can start to put your efforts in wanting to feel better and starting to exercise, the way you feel after really helps motivate. I had barriers in my pain medications. I had been clean for 10 years from hard drugs, had done a detox and no longer was destructive substance user. My Hep C treatment and I changed my life. I quit drinking for the treatment and, now I'm down to cannabis. So, but my challenges really for exercise and chronic pain are prioritizing my health. Before I had other issues and now, I focus on my work and I'm buried into my work really as a coping for COVID and a lot of time and isolation. But, prioritizing my health is difficult when I'm in pain. The motivation is just so hard and to maintain it, to do it day after day. And I'm learning to have to be kind to myself and not to set realistic goals. That's the main thing is, to be realistic in my expectations and my goals. Depression is another factor in impact. The exercise helps. It helps immensely. But with pain, I'm unable to. So I'm feeling a little bit more depression and I've gained weight. So it's kind of an evil cycle, really. But I do know, I've been in great health. I've been in not so great. Right now I'm on a hiatus because I'm in so much pain. But I know that if I get back to it, one step at a time, that I will feel better. And it just sort of multiplies in other areas with appetite. It's better for my health. When I exercise, I smoke less. There's just so many benefits. But it starts with the commitment. You have to make a commitment to your health and you have to prioritize your health and you have to find strategies to keep it up. And, I face so much stigma regarding my pain medications. Like I said, I was denied for 10 years. And it took an MRI from my HIV specialist to finally be granted pain medications. More recently, I had 2 hospital stays, 12 days, and they missed my heart, if you can believe it. They were so focused on my drug seeking because I was in the worst pain of my life. It totally overloaded me, the angina. I needed 5 stents. So they were telling me while it was in my head and all this kind of stuff. They weren't giving me pain medication, stating that they couldn't understand. What I really needed was 5 stents. But stigma for people with substance use or past substance use, and my medical file follows me everywhere. You can imagine my luck when I first went for pain medications so very long ago. And they were denied because I was a substance user. So there needs to be a lot more flexibility and realization. Yes, I use drugs harmfully, but I don't anymore. I use them for pain. There is a huge difference. So, I found another thing very useful for motivation is what I call Pavlov's dog. I actually smoked a joint before I went out for my round around, doing my rounds walking. And, just use a treat or something. I know even in the worst shape that I am right now, when the golf course opens up again, I'll get out. I mean, I played golf with stitches on my thumb. So, that's another way is find something that you really love or you know, little treats, you know, whether it's a special snack or music or whatever, something to help motivate you. You know, if you do your exercise, you get a little bonus. So those were really my thoughts. You know, exercise is so critically key. And, you know, I do believe that exercise programs such as the one that Kelly's doing could really spin off into support and is so needed. And it could help people in other ways with their exercise. They may pay attention to their diet. They may pay attention to their smoking. It's all good.
Colleen, can I ask you, is there one type of exercise that for you helps you better than anything?
The best exercise on the planet is walking. I mean, especially if you're in chronic pain. And you can start from zero and work your way up, and you will feel better. I'm a big believer, you know, it doesn't have to be fancy. You know, I put a headset on, I put my Spanish music on, I might smoke a joint, and then off I go. You know, whatever works for people, but to find motivators.
Okay, thank you, Colleen. And Ron, same question to you. What's been your experiences living with HIV and physical fitness? Since you're the yoga master.
Let me put it this way. When I discovered yoga about 25 years ago, to me it was finally finding something that I actually enjoyed. Because I didn't like running. I did some weight training, which was okay, but I really came to love yoga. I'll have the first slide. And, you know, I didn't take any of these poses this morning because, of course, you know, I didn't want to show off. And of course, this is me, you know, using all the facilities at home. So yoga doesn't have to look like that. And it doesn't, because I can't do that. Although I can actually do a headstand, and I can do a supported handstand. We'll have the next slide. But yoga, of course, can look like this. And there are many wonderful ways in which to move your body, use your breath, and get into the choreography of yoga. And I think that's what ultimately attracted me to it, was that it became the thing that I could do that made me feel the most like I was a dancer. And that has always held some appeal to me. And maybe because my mother had scoliosis, and she went on to study Cecchetti method ballet and opened a ballet school in Ottawa, where I grew up. So I was always a bit of a frustrated dancer and thought my mother was pretty incredible. And as I say, it's really important to find something that you enjoy doing. So I was doing it, and quite strenuously, well before I was dealing with pain related to arthritis, which does seem to run in my family, along with osteoporosis. I'm sometimes fond of saying that I come from a long line of skinny people, because I do. And while I think there are many health benefits to being on the slim side, there is a tendency, of course, to have osteoporosis. And then there's, you know, this stuff that runs in the family, like the arthritis and the osteo. And then there are things like the neuropathy, which Joe discussed in great detail. But I just want to add a little bit to what Joe was saying about neuropathy. In my case, the neuropathy dates back to the earliest days of the epidemic. I started taking drugs in 1988. I started with monotherapy with the dreaded AZT, or for our American friends, AZT. Went on to dual therapy with other thymidine analog drugs with names like D4T, DDI, and DDC. which are well known to cause neuropathy. So to this day, I'm well aware in the literature that many people who've been living long-term and taken a long history of drugs are experiencing forms of neuropathy with a different source, really, than was the case that Joe described so eloquently, with different degrees of severity and so on, but certainly an indication of the need to collect data which really begins to tease apart and disaggregate how much time people spend on drugs, how much time people spend with low nadir CD4s, what the amount today and role of is the role of low-level viremia in causing inflammation. These are areas we can go into in a little more detail when we talk about the research. But those were some of the sources of pain that I was dealing with. And certainly there are many benefits to yoga and other forms of exercise. Yoga being one of the most studied forms of exercise these days in terms of its benefits for people with HIV. So you can see the benefits in terms of improving strength, balance, which we lose as we age, and flexibility, which of course also diminishes with age. And the wonderful thing about yoga is that you feel, or ought to feel, your way into it very, very slowly. So you're always conscious of how far you can go and allowing your body just to tell you how far to go on any given day. And that can look quite different from day to day in terms of your flexibility. You have days with greater flexibility, days with less, but over time, flexibility really, really does increase. It can help with back pain relief, although again, you have to be very careful and cautious because people have disc issues which are not always amenable to relief through yoga. And I think you need to work with somebody who has a background in therapeutic yoga who can make sure that if you have back issues, that yoga will actually help them improve and not make them worse. I definitely find that the yoga helps me with my arthritis symptoms, including both joint pain and flexibility. And as Colleen mentioned, there's nothing like walking. For me, this has really become a use it or lose it strategy. I've been trying to understand the degree to which my arthritis improves when I warm up my joints. And I think this is really, really crucial. And I try to use pain medication in a very, very secondary way. Let me just also point out there are some other bullet points here to talk about the benefits of exercise and yoga in terms of your sleep, your energy, your mood, managing stress, and its impact on heart health and blood pressure. Very importantly as well, number 5, that yoga is living proof that what's good for your heart is good for your brain, and that it can help enhance executive function and memory as we age. So there are many benefits in addition to the ones we're here to talk about today with regard to joint pain. I'd also like just to say a few words about my use of medication and my use of supplements. I'm someone who, because I take and have over the years taken so many medications for my HIV, I really try to control the number of medications I take for other things. So I've been playing around with pain medication, and I think, in fact, that I had masked the pain of arthritis for many, many years by using NSAIDs, or non-steroidal anti-inflammatory medications like Advil or ibuprofen, like Aleve with naproxen. And then I discovered, like many people living long-term with HIV, that my kidney function was somewhat compromised. And I was told, really stay away from the NSAIDs. And if you're going to take a pain medication, take something like acetaminophen under the brand name Tylenol, just as an example, which is what I do, but I don't find it very effective. And now I'm in conversation with my doctor. And again, this is something I advise people to really think about, is whether you have actual kidney dysfunction, whether your kidney levels are maybe being raised by one of the medications you take. For example, tenofovir might have that effect. Whether over time the kidney function is so low that on the days when you're really going to do something that requires pain management, on those days you could actually take an NSAID. So I've been playing around with all of that, and I really look to my doctors for advice and guidance on the degree to which my kidney function is stable and will, allow me to take certain types of medications, and using Tylenol on days when I'm, not managing lower amounts of pain or have less strenuous things to do in my plans. I want to talk just as well, as I said, about supplements, because I've always, and because I had HIV well before there were any medications at all, I did a lot of research into supplements. I still use a number of them. So I'm using supplements like glucosamine and chondroitin to manage collagen production and to mitigate joint pain. I do take omega-3 fatty acids. I have for a very, very long time. I know other people are using MSM and pycnogenol and SAMe, all things that people try with varying levels of success. And most recently, I tried CBD products, both a topical ointment under the Live Relief name, including equal amounts of CBD and THC, which I did not find to be effective, and CBD oil at night, which actually managed to make me a little bit high when I took too much, but didn't seem to have any impact on the arthritis. So again, another area where I would like to see a lot more research being done into the use of CBD for arthritis. Those are some of my initial thoughts on medications versus supplements, and above all, the benefits of exercise and really keeping moving, use it or lose it, and find something that you actually enjoy doing. And I'll stop there.
So Ron, I have one question for you. When you started, and this is for everyone, maybe you and me, wanting to learn about yoga and get involved in it, was it important for you to do it on your own, or was it more important for you to have a buddy or someone to keep you on track and keep you going, doing it every day, day to day?
Back in those days, the pre-COVID days, and I'm actually talking now about back in the 90s when I started yoga, I loved doing my yoga in a class with an instructor who was very hands-on, and by which I mean hands-on. Some people said to the instructor, please do not touch me. I was not one of those people. I was, please show me what I'm doing wrong, where I have to move. And not only did I love the hands-on approach of being in a class, I loved doing yoga in a room with other people where I could hear their breathing. And I would feel as though we were all breathing as one gigantic organism. And I miss it. Frankly, I miss it. But I'm also happy that we have some resources that are available online. And now I've become quite used to doing my yoga at home. And I really like to mix it up by doing yoga with Adrienne. Adrienne also has sessions on chair yoga for anyone who's interested. And her website now, I think, has some 500 yoga classes, all at different levels, all varying lengths. And I'm not doing it alone, and I'm doing it with Adrienne, and she's wonderful. So check that out. Also, the website, doyogawithme.com, promoted or recommended by Adria Quigley, is a wonderful website with many different instructors offering many classes. Some are for pay and many, many are for free. So during the pandemic, I'm really, really happy to be able to do yoga. And where you saw me on my mat this morning, I have a TV within range where I can put Adrienne on and lovely music and happily do it at home.
Thanks, Ron. And Francisco posted a message, and he's asking, Ron, are you aware of any programs in Canada or Ontario or other places that support positive people with funding for supplements?
There used to be some funding for supplements available through programs of the Toronto People with AIDS Foundation. I was very involved back in the day setting up a naturopathic clinic, which is located at the Sherbourne Health Center. And supplements for people and care offered by a naturopath are still offered, to the best of my knowledge, through the naturopathic clinic at the Sherbourne. But I imagine that that's pretty difficult in the these days, and hopefully we'll resume when we're able to resume a more normal life. But that's one place that people could look into.
Thanks, Ron. We're going to move over to our second question, which is now looking a little bit more on the academic side and research and community-based research initiatives related to chronic pain. So I'm going to ask Kyle to give us a little bit more perspective on his side of what's been done on the research side.
Great. Thanks, George. So I wanted to start off first by just acknowledging that in recent years, there's really been an increasing recognition publicly in terms of the burden of chronic pain. So for example, here in Canada, the government of Canada recently formed the Canadian Pain Task Force, which will recently be coming, or soon be coming to a close. And they've released 2 reports so far, and the third one's actually going to be released sometime this week. But it's really looking at how we can better meet the needs of people broadly who are living with chronic pain, and in particular looking amongst certain groups that may be more likely to experience pain than others. A guideline was also recently published through Health Quality Ontario here in Ontario, which talks about what are the quality and high value aspects of pain management that we should really be placing efforts into. And within those, amongst the 11 statements, physical activity and therapeutic exercise were both recommended as aspects of pain management that we really need to be focusing on, and that if we want to be providing quality care as healthcare providers, we really need to be looking at how we can make both physical activity as well as more targeted therapeutic exercise accessible to people who need it.
Great.
Now, I wanted to highlight a project here that was led by the University of Toronto physical therapy students that myself and a few others supervised, where we interviewed people living with chronic pain. This was not specific to people living with HIV, but people living with chronic pain broadly, about what they were looking for in terms of community-based exercise programs, because I think that's really somewhere that we need to focus on. We know that specialty care can be quite challenging to access. So myself, for example, where I provide clinical care from is at a tertiary care chronic pain clinic where people require referrals to access us from primary care. We know that there are lengthy wait lists and there isn't geographical equity as to where we are located. Usually tertiary care pain clinics are located in larger urban centers, often affiliated with universities, so they're not accessible to everyone. But really, when I think of what are the potential values of community-based programming, it's highlighted in a quote here by a participant, which you can read. But really the essence is that getting out and being around other people is a really helpful piece of engaging in community-based exercise, in addition to the physical benefits of exercise, which I think aligns with kind of what many of the panelists have said today, and thinking back to what Ron just mentioned around being in a room with other people all doing a similar activity can just help with not only motivation to engage, but also your overall enjoyment. I also wanted to highlight that I think, a promising area that we may want to focus on is in particular primary health care. So primary healthcare being the first stop in the healthcare system. Traditionally, we've thought of these as going to see your family doctor. Here in Ontario, we're seeing an increasing shift onto team-based models of primary care, where multiple healthcare providers are under one roof. I believe the Sherborne clinic that you were speaking with is, I'm not sure whether it's a community health center or a family health team, but I believe they fall within that model, where individuals are able to get access to an interprofessional team, and it's all publicly funded at no cost. We recently did a survey of physiotherapists working in primary care teams in Ontario, and exercise programming is a core component of care that's provided by physiotherapists. So this may be a potential route of improving access to physical activity and exercise interventions that do not have a cost because it's a publicly funded program. So just kind of highlighting that primary care and interprofessional primary care may be a particularly promising point that we need to focus more on. I also wanted to highlight recent work that a few of us on the panel and on the call here today worked on, where we looked at understanding the strengths and challenges of implementing physiotherapy within an HIV community-based care setting in Toronto. Among the participants that we interviewed who engaged in physiotherapy, so people living with HIV, you can see in the green box there that muscle pain and joint pain was a very common symptom that people reported. So highlighting a specific strength of integrating a physiotherapist directly within this model of care was such that the physiotherapist was co-located with other healthcare providers. It helped to decrease barriers to accessing care. So again, this may be another promising route if we look at specialized HIV care services of including individuals and healthcare providers who can provide exercise-based programming. And this could be physiotherapists, but it could also be nurses, occupational therapists. There are many healthcare providers that I think this would be very amenable to. So that's a quick little snapshot. I'll leave it there.
Thanks, Kyle. And Joe, what's been your experience in research and community-based?
Well, I noticed that in Kyle's study, the age group, average age was 57, Kyle. The HIV population is getting older because basically we're not dying. And that does mean that there will be so many more comorbidities present, as there are with anybody who is getting older. Some of which are absolutely not specific to HIV, but shared by very many others. And things like the frailty score, which measures a number of different symptoms that can lead to you being diagnosed as frail. There is a clinic in the south of England, Brighton, some people may have heard of, a seaside town. There is a very well-established clinic there which looks at what does affect older people. I have taken part in some of the research with that clinic and helped to recruit people to be part of the research. But quality of life is now in the UK at a sort of equal level of emphasis to HIV prevention and testing. In England, there is an initiative to eliminate new HIV infection, new HIV transmissions by 2030. Those of us who already have HIV, partly with a sense of, well, you know, sort of close the stable door, the horse is already bolted, but partly because we don't want to be forgotten in all of this, are looking towards quality of life. And you know it's important and popular when every pharmaceutical company in the HIV sector has quality of life programs. The World Health Organization is looking more at function than quality of life, but it is looking at what happens as people get older and seeing it as a right to have a life that, if you like, is worth living, that is supported by, where necessary, rehabilitation to ensure that the individual's ability to live an ordinary life is helped, is preserved. The World Health Organization Rehabilitation 2030 meeting I took part in, it was looking at many conditions that caused quality of life or function, depending on how you want to define it, as falling. And I was speaking about HIV, particularly because the episodic nature of neuropathic pain, of other conditions in HIV, was not really very well understood. Other speakers, including somebody who could barely move because of a car crash. I mean, there was an awful lot of variety in it, but it is a hot topic. There is a desire to fund and improve it, particularly in countries where there is very little support, so that living well is something that is available for all people, whatever condition they're suffering from. And measuring what living well actually is why the study I have highlighted below, patient-reported outcome measures, is important. It was looking specifically at HIV, but patient-reported outcome measures, or PROMs, to use the now popular acronym, is simply a checklist. It's a checklist that could or should be run through with a patient by a clinician every time they see them, in order to see if there has been, this is self-reported checklist, an improvement or a fall in their mental health, for example, their mobility. And that could mean that in a short time, because nobody is funded to have long consultations these days, in this country being the UK that I'm talking about, I'm sure the same is true of Canada and other countries, of those people who are listening, it means it will be possible to do that. Maybe the patient themselves could go down that list carefully before they actually see their clinician. So their clinician then knows what they should focus on, so they can investigate the causes of whatever is worse, or whatever, in fact, is actually better. The open study is looking at a form of cognitive behavioral therapy. I helped to develop the study, but more than that, I helped with the language of the workbook that was part of that study, the recruitment of the people who were part of the study, and then giving feedback to the people who participated. One thing researchers can forget is that if you did take part in a research study, you really want to know what the results were. And the likelihood of you or anyone that you know or talk to taking part in another research study is dependent on how much feedback you actually get, because you're taking part because you want things to improve, you want things to change. You're one of the people. If you are not, if it's a random controls trial, if you are in the arm, which is the treatment as opposed to the placebo arm, and you hope you will be in that arm. With the open study, because the impact was so clear, everybody who was in the placebo arm, who didn't get any treatment, then did when the participants had completed it. To give you just a little information as to what it was, there was a series of videos, 6 videos, I think, if my memory serves me right, which showed different stages in online modules. It was done online, but participants had the opportunity to have a conversation after a particular module. If they had any questions, they could request contact from one of the people leading the research, who would then call them back and have a short conversation. We're talking like 10, 15 minutes. We're not talking an hour of online turning into verbal therapy here, in order to see how they were progressing. And a lot of different sorts of techniques were progressed through the workbook, through the videos, and then through those conversations. At the moment, they're looking to see if the study, which was basically a feasibility study, can be funded for basically extension to a broader group of people. So that's a bit in the UK. Looking more globally, and we are now, by magic, about to look more globally, I am part of the HIV Global Pain Task Force. This happened because a group of HIV clinicians and researchers, and in fact, I know I was the only person who actually lived with HIV and pain who happened to be at a conference in 2019, got together to literally brainstorm, spending half of a day brainstorming what should be researched, what were the priorities, what did we understand, what didn't we understand. It will come as no surprise to anybody who is taking part of it that there is very little really actually known. There is very little evidence-based research on how to optimally manage pain in people with HIV. The medications that are available depend largely on the individual as to whether they work or not, how they use them. Personally, I became concerned that if I used fentanyl or other patches, which were basically giving me morphine through the skin, they stopped working, so you go up a grade. I was increasing my intake of morphine. I'd done everything in terms of tablets that I thought I could take. And when I was in the Chelsea Westminster Hospital, where I was for 2 weeks being analysed by all sorts of tests from all sorts of different specialists, the pain was such that it was my wheelchair phase, that I was actually given liquid morphine. And, you know, guess what? It worked. But guess what? I didn't want to go on taking it. I know far too much from people I know as to what could happen to me if I continued to take it. So what were the research priorities? There was an agreement from response to a questionnaire to the clinicians, researchers who had gathered from the US, the UK, Canada, and South Africa as to what they thought the priorities were. But it was very important to also check what people who are actually living with the pain, people with HIV who are living with it, what they wanted to know. For example, is it more important to know what causes it? Is it more important to know what will actually alleviate the pain? Is it more important to know what's associated with it? And so a questionnaire was developed and edited with the help of people living with HIV. And it's gone out in the US through a magazine which you may all know called POS News, an online magazine. The response has been largely biased towards MSM, men who have sex with men, which tends to happen for one reason or the other. And so it is important in the US to broaden that, and there is work going on at the moment to do that. And the questionnaire needs to be tailored to the UK. Some of the medications, for example, quoted in the US are not available, are not prescribed or prescribable in the UK, including medicinal cannabis, for example. And so that is happening at the moment. It will then be shared through the UK Community Advisory Board, which you may remember is a network of 800 activists, treatment activists from, in fact, about 120 organizations. With the online website and the message board we have with that, we would be able to get it out far and wide throughout the UK to see what feedback there is from that. But I think it is very heartening to know that there is a global pain task force, and that task force is looking at causes, at treatments, so that things will, when research is done and when that research is reported, we'll know what will be helpful for all of us. Exercise is one of the things that's being researched, obviously. How relevant is that to what we're talking about today? And different levels of exercise, because there is a certain amount of availability in terms of specialist support. As already said, in the UK, there's very little specialist, and all of us may need to broaden our activities in the way Kyle was mentioning, in terms of looking to other conditions where there is pain and there is a need for exercise, in order to join with them in getting support. Perhaps it may be stroke, for example. Who knows? Many other conditions. There is, in the UK at the moment, a very, very interesting and exciting 3-year study which is about to begin. I can't tell you what it's called, but there is the word pain in it. And I can't tell you much more because it hasn't actually been announced yet that it will be funded. But that has people living with HIV really integrated into the study, as well as people who are suffering from pain for other causes, whether it is arthritis, rheumatoid arthritis, whether it is as a reaction to an accident. And that, because it has so much patient involvement, I am confident that it will deliver results that will benefit all of us. And I'm sorry I can't talk more about it or explain more about it at the moment. And before I end, could I just say that I think that I may seriously be considering moving to Canada. Things seem to be so much better there. Thank you very much.
Well, actually, Joe, that brings me a question for you, because we're talking about socialized. I think you talked a lot about socialized medicine. I'm looking at all these countries that are involved. Has there been a difference between countries with socialized medicine versus privatization? And I'm going to use the U.S. as an example. Has there been much differences in those studies that you've been finding?
I think where the difference has come has been privatization is not as bad as I thought it was, to be honest with you. I thought it would stop people from getting what they should get and support that they should have. But it doesn't seem to be that bad, because in the UK, we are so proud of our national health system. But our national health system doesn't actually help people like me. And I'm more than capable of arguing my case if I want to get physiotherapy, rehabilitation, let alone exercise, which would support with pain. That's come through individuals, and it comes through dedicated individuals who are clinicians and researchers, and or through peer support groups, the community groups that there are, who try to work with the YMCA, which has been mentioned already, work with other organizations to enable people to get the support. And I guess that's probably true wherever you are.
Thank you. Colleen.
Hi. Just a quick question. Will we be doing the third question as well? Or should I integrate it?
Integrate it for now.
Okay. Well, my research interests and my focus for the last 3 years in chronic pain was inspired by my lived experience, much like my co-infection work. I mentioned earlier that I've experienced every barrier, every stigma that there is in pain management, in access to treatment, care, and support. I've suffered in silence really for the last almost 30 years with my chronic pain and HIV, never realizing that it was a huge advocacy issue. I just sucked up the pain and did 100 other things. I'm involved on so much research in the last 15 years, and chronic pain and HIV simply is not on the radar in Canada. It's missing from the treatment cascade. It is a silent epidemic. There are so many of us impacted. And the need is so great, Kyle, for epidemiology, for services, for policy. It was Dr. Whitney Scott's article that I really read 3 years ago. That was the first I'd really seen on chronic pain, and it was focused on the psychosocial impacts of chronic pain. And people living with HIV. And it really opened my eyes. And I realized all of the things, all of the barriers, all of the things that I had experienced need to be addressed, and that I wasn't alone. I've spent the last 3 years working very, very hard to try and bring awareness and to create research and research opportunities. My first focus was the OHTN Ontario Cohort Study Governance Committee, and we had a short questionnaire added to the existing study. And there's 3 years of data there now, and it just needs to, be tabulated or something created to connect it with exercise, and then we'll have some research on chronic pain and exercise that's psychosocially based. We need leaders. We are looking for team members. Other work that I've done specific to chronic pain and HIV, I joined the Global Pain Task Force, also with Joe, and it's just a phenomenal group doing phenomenal work. Joe's already covered, the bulk. So all I can say is that I'm very honored and very pleased. I really believe that they're gonna pave the way forward globally. And in January of this year, I was responsible for creating a working group at the Clinical Trials Network. And it's a multidisciplinary team. It has people with lived experience. Everyone is committed to finding out how many, what's needed, what helps, and what are the gaps for people living with chronic pain. The working group, I created a webinar series, and very much I want to look at wellness and I want to look at exercise. And this team will be building and developing a webinar series. The first presentation upcoming will be on measurements. And our goals are to set up a small subcommittee focused on measurements, and to perhaps do a national survey, which is something that I've been pushing for 3 years. We do need a national survey in Canada, reflective of diversity and geography. Canada is unique in many ways, and we need this data. So I started the clinical trials working group, and we're going to be focused on our webinars. We're going to be focused on creating add-ons for new existing surveys. And this working group, it's possible if anybody is interested, if they would like to join a working group meeting, or if they would like to join any of the webinars via the Clinical Trials Network. You can inbox me if you like. My email is coinfection@sympatico.ca. This group isn't focused, specifically on exercise, but wellness, resiliency, health, 100 other things. And we're just starting, and I'm very, very hopeful that this initiative will really pave the way forward in Canada. This group is very blessed to have the assistance of Dr. Jessica Merlin, Dr. Jessica Robinson-Pat, and Dr. Whitney Scott on our CTN working group to assist. They are the global leaders. There's a shortage of leaders in Canada. There's a shortage of researchers in Canada. I really, really encourage researchers to consider chronic pain. It's been ignored. It's a silent epidemic. And there's such a grave need for research. There basically is none in Canada. I'm pushing very hard to get training programs started at CTN, possible fellowships. I've been pushing for funding left and right. Our government needs to step up. The National Task Force is in the right direction, but it does not address people living with HIV in specific. And we are a distinct population with distinct needs, and we're higher at risk. And social determinants of health, poverty, have been the greatest barriers. It is not a level playing field for access to treatment, care, and services. And even within populations, there's vast differences. So again, there's so much work that needs to be done. I encourage researchers to, jump into the chronic pain work. We need everyone, and this work has to be led by people living with HIV and chronic pain. By us, for us, together with us. We really need to make changes. We need to push for programs and services. We need to push for policy. And they can't make excuses for no funding, no services any longer. Too many people are dying, and quality of life is so severely impacted. We need to do better. Thank you.
Thanks, Colleen. And Ron, do you have anything to add to what's happening in research that you know of?
Hi there. Both Joe and Colleen, who are living with severe and serious and long-term chronic pain, I think have done a really, really great job of covering some of the research priorities. And I don't want to repeat what they've said. I was just trying to think about what I would add that maybe hasn't been stated quite as clearly or didn't come up in terms of some of the things they mentioned, or maybe I just didn't hear them. But Colleen just talking about the kind of data that we need, to do a better job of collecting, for me also includes race-based data, gender-based data, as well as data on trans folks who sometimes, get caught up in a binary of male-female, but really need data collection that is dedicated for their specific population. I certainly agree as well that we need an emphasis on data that will support what I would call the fourth 95. As we move from the 390s and look at targets for set by UNAIDS, we're now looking at the 395s, and a number of us are working on the fourth 95, which is quality of life and wellness indicators. So I think there's obviously a lot of room for research around that, and Joe mentioned it quite specifically as well. For me, there's still always a lot of work to be done in understanding disease progression and trying to tease apart the aspects of understanding what is specific to pain as it relates to the intersection with HIV. For me, has to do with always understanding how much of it relates to the drugs we take, the time we spend or have spent on those drugs, and the impact of low-level viremia, which to me is also very significant, particularly in terms of our understanding that one of the things that's exceptional about HIV is the degree to which, while our virus is, for many people, very well controlled, there is still low-level viremia causing greater levels of inflammation when compared to the general population. In addition to that, I would like to see more research into non-drug interventions. I've always been interested in complementary and alternative medicine. And I think that's still an area which, in which we end up with a whole lot of kind of very small pilot studies that are difficult to get funded into larger studies. That's a shortcoming I would love to see corrected. And finally, more research related to interventions and comparisons where we look at exercise and non-medical interventions compared with other medical interventions, also compared with the use of supplements and so on. I think there's a lot we still have to learn and need to learn, partly because, as some of our speakers, and Joe particularly mentioned, a lot of us have concerns about using more powerful pain medication with the risk of the potential for addiction. It's not really my personal area of expertise, but those are my thoughts.
Thanks, Ron. So unfortunately, we're running a little on time, so we're going to drop our third question, and I'm going to open it up to the audience that's here for any questions that anybody has. Please either post them in our chat box, or if you'd like to unmute yourself right now, we'll take about 2 or 3 questions quickly. So anybody have any questions for our great panel? And we'll keep monitoring. Are people busy typing in the chat? Well,
hi, George. This is Greg. Actually, I have a general question for everyone. I posted it a little bit earlier in case I don't phrase this correctly. I've noticed that there's. I was interested in the way Kyle was actually defining pain, because it opened up the idea that I've noticed, which is the interplay between other symptoms and pain, and how exercise can be detoured as a result of the connection of nausea or feeling cold or triggered feelings, those sorts of things that feed pain and make it more difficult to motivate. So I was wondering from everyone what they might suggest in the way of intervention and or research around methods that might work to assist people in getting into exercise, using methods pre, during, or post that might help these other symptoms or the interplay.
So
Thank you.
Thanks. I'll open it up to the panel who wants to go first. Anybody have any comments? Joe?
Just that the interplay of other factors, I mean, it sounds like an obvious thing, but it's not an obvious thing to very many doctors, that there will be inevitably pain leads to depression, depression leads to pain. There is an exacerbation of pain if you do not sleep. So one of the things I found most helpful recently in looking at new research, which is just in the process of looking for funding, is the definition of pain as being something which is always very individual, and that it is and can only be defined by the person who is experiencing it. And I think it's very important to remember that, because that does take in things like Greg was just mentioning. I mean, if you're living in conditions where there isn't enough heat, and that might be because you don't have the money to pay for the heat, and you're cold, your pain will get worse. I know perfectly well that in the winter, I'm wearing layers and layers, and wearing those layers does mean that the pain is reduced or less likely to become worse. And it must be understood that it is up to the individual to say they have pain and to maybe suggest why they have pain as well, if they can see that there is a relationship between what they're doing or even what they're eating and what the state of their pain is. Ron was touching on diet. I myself try to eat extremely healthily. I don't eat a huge amount of meat. I eat meat very rarely. I do eat a huge amount of fruit and vegetables. And I do take vitamins and the odd supplement, perhaps not quite with the study that Ron's obviously put into it.
Thanks, Joe. So there is one in the chat room that I'm going to read, which is, and I'm going to open it to the whole panel. Is there any evidence for what dosage of exercise, frequency, and intensity is beneficial in chronic pain caused by HIV? I'm going to start with Kyle. I think, Kyle, this is something maybe the studies that you've done might help.
Yeah, I mean, what we know broadly in chronic pain is that people who engage in regular physical activity and exercise have greater health outcomes than those that do not. But there isn't compelling or strong evidence that one form of exercise is better than another. As Joe nicely put, we know that pain is a personal experience, so it's really about individualizing and tailoring to the individual. But from what we know right now, one exercise is not better than another. I think the principle of the best exercise is the one that you enjoy and will complete and will be able to engage in over the long term is probably the best one. With that being said, there are certain strategies that can be helpful of how we approach physical activity and exercise when you're living with pain, whether that's taking a graded approach, using pacing strategies, using distraction, taking more mind-body approaches can help to facilitate. But in short, from what I know, not one exercise is better than another when we look at most chronic pain conditions.
Great. Thanks, Kyle. Ron?
I read, while I was sort of preparing for the panel today, something to the effect, and it may have come from Adria, who's in the room today, but I'm not sure. But it was to the effect that in terms of yoga, for example, today my demo was somewhere in the neighborhood of about 12 minutes. And I read that if you did just 12 minutes a day of yoga, that would have a pronounced benefit. So again, I think in addition to what Kyle is saying about, finding something that you enjoy, and that was something I had said as well, that you don't need to do a great deal of it in order to derive a benefit. Starting is often the hard part. And I think you have to really, really figure out how to ease your way into it, do a little bit of it every day, and then just try to increase it. So, if I can do 4 to 5 days a week of about 20 to 30 minutes of yoga, I feel pretty good about that. And I also try to get out and walk, try to get my 10,000 steps. I'm not always successful, but I get somewhere between 5,000 and 7,500 steps, again, 3 to 4 times a week at least. And then I have less guilt about the chocolate cookie I eat when I get home.
Yeah. Great. So thank you, everybody. We're going to move on. See, there's a link to our evaluation screen, so please take a second and put your name in for our draw to get everything we all need, which is coffee. We all need that coffee break. So please click on that link that's there, and I will email that link out to everybody also, because your response back to us helps us improve these sessions going forward. Again, like Kelly says, the next one is September, so our theme also for then will be see you in September. So thank you, everybody, for joining, and thank you for being here. And please feel free to complete the evaluation, email me if you have any comments, any questions after today's session. That'd be great. Thanks, everybody.
Thank you. Bye.
Thanks, everybody.
Bye.